couple of days ago, actually, a 35-year-old chap who came with a heart attack again. He came walking into my consultation chambers, actually, with chest pain, took an ECG. It's a hard, I had to give him the bad news. Look, I'm sorry, you're having a heart attack. We'll have to admit you immediately and treat you. So, yeah, it's very strange. It's hard to, again, say why exactly it's happening at young ages. I think it's multifactorial. I think a lot of things are happening in the world that potentially is causing these. If you go by science, which I am a firm believer of, heart attacks, as I mentioned, happen because of certain risk factors that we have.
Hello everyone and welcome to the Docs podcast. Today we have a very special guest, someone who literally has all of Colombo's heart. With me today is Dr. Chamara Ratnayake. He is the resident cardiologist of Asiri Group and also someone who very specifically and clearly said, don't talk too much about my qualifications.
Absolutely.
He always says this and I really appreciate him for that. Humble man, great chap, and as well everyone's, I wouldn't say heartthrob because his wife will kill me, but definitely has everyone's heart. So first of all, Chamara, thank you so much for being on the show. We have a lot to talk about.
Thank you for inviting me, Sunit.
It was my pleasure. So Chamara and I go way back. We're both from the same school by the sea. And when I say we go way back, that sounds a bit dangerous, but we've been friends. So... And
not with benefits.
Not with benefits. Thankfully, not with benefits. Yes. Neither of us bet for the same team. But anyway, so Chamara, let's talk about a few things that patients commonly ask you and me both. We both have faced with these common questions. So since you're the heart specialist, what's your take on cholesterol? How does it kill us, and why the whole issue with it?
Yeah, that's a good question to start with, Sunit. Cholesterol is, of course, something that we see day in and day out. And, if you ask patients, some of them will come to us with these random reports and saying, doctor, my cholesterol is high, or et cetera, et cetera. So we are talking about, from a heart point of view, as being a cardiologist, so we talk about potential reasons why somebody might end up with a heart attack. The reasons that can cause a heart attack can be divided into many categories, but we talk about the risk factors, as we call it, that we can control. Mm-hmm. And one of those risk factors that potentially can lead to a heart attack in the future is cholesterol. And what I'm talking about is long-term as well. Just purely because you have a bit of cholesterol now doesn't mean that you're going to end up with a heart attack tomorrow. It's all, you have to think long-term down the line. So cholesterol is one of them, high blood pressure is one of them, diabetes, high sugar is one of them, and smoking cigarettes is the other last one that we can potentially control. So of them, cholesterol definitely is one of those important risk factors that can lead to heart attacks in the future. And that's why it's important to know about it and talk about it and see what we can do about it.
Yes, excellent. Actually, now that you mentioned all of this about cholesterol, let's pick up on a common question that you and I are both faced from patients. So, infamous issue is that when cholesterol is under control, they come and ask you, now, doctor, no, my cholesterol is normal. Can I stop the medicine?
Yeah.
What do you have to say about this?
Yeah, if I were to get a rupee for every time I get that question asked. But yeah, it's a common question, unfortunately. Yeah, so I think it's about lack of education in that sense, isn't it? So that's why I give in a few minutes whenever a patient comes in for a consultation to explain to them the reasons as to why we start them on medications and the benefits of taking them long term. So as I said before, all of these risk factors, Sunit, that we spoke about that can cause a heart attack are risk factors that will be in you long term as well. And the reason for that is majority of them are because of genetics. And unfortunately, genetics is not something that we can deny, nor can we fight off and say it's done and dusted. So genetics is in us. So we are born with it, essentially. So cholesterol, and in particular, certain types of cholesterol like LDL cholesterol, which is a genetically determined cholesterol, and other types of bad cholesterol, as we call it, are things that we are born with. So it will be in our system, and you've been having it from the day you were born, and it will gradually accumulate. And for example, if you are coming to me for the first time with a a cholesterol report which shows there is, high amounts of LDL cholesterol, I always tell my patients, look, I know you came to me with this report now, but unfortunately, I'm pretty sure that if you had checked it a few years ago, a few months ago even, it would have been at similar levels. And all of these tend to accumulate in your body and in your heart and in your arteries, and in particular from the heart side of it, we are talking about the coronary arteries, which are the blood vessels that supply blood to the heart, and these go on accumulating over time. And the reason we start medications is to reduce it and continuously or persistently keep it low. That's the important thing that we want to do. There is no point in taking tablets short term to reduce it. Let's say, for example, 3 months, you reduce it and then stop it and then get the levels up again, because then it will start accumulating again. Correct. So, and then it can lead to, heart trouble in the future. So the important thing to answer is that, yes, we need to figure out. So first point is whether you actually need tablets or not. So that's a contentious issue, isn't it? So so sometimes there are people who have cholesterol where we might tell you, okay, look, your levels are not too bad. Okay, I'll give you a bit of advice on lifestyle. Let's see whether we can drop it down to certain levels by lifestyle measures alone. But it depends on the thresholds. There are certain thresholds. You can't look at a patient's face and say, this level is what you need. It depends on certain other factors as well. So we tend to look at the numbers and see what the numbers are, and certain people will fall into a threshold that they will require medications. And if you require medications, that means that you will have to take it long term for those long term benefits. Correct. So that's what I always say.
Right. So, interesting point you brought up there about medication. So, I believe you and I, strangely, Chamara and I have both had the same question from a patient to which we gave the same answer. Another common type of patient that you and I both get are our posh aunties who come from, that segment of society which loves to use Google as their doctor. And they will Google the heck out of any medication or any condition, and then we have to un-Google it, right? So, that's sort of.
I think that will be in the dictionary soon.
Exactly. Well. We have to put some sense into the fact that, into what they read, or rather grounding. So, so one question I was asked, since we spoke about cholesterol, is this lady, she asked me, but doctor, you want to start me on rosuvastatin. There is a study that says that rosuvastatin causes dementia. I mean, I'm not very happy about this. Mind you, Chamara, I'll be honest, that was the first time I learned that rosuvastatin causes dementia, because I wasn't aware of that particular, the incidence of the side effect, how much it causes, to answer her question. Because Google will tell you, everyone gets it, or you will read it in a way that, you read what you want to see, you see what you want to see. So this was her concern. What would you have to say about this?
Yeah, again, these are questions that we are asked as cardiologists whenever, because people read a lot, as you said, and information is available, and sometimes they say too much information can be harmful as well, and I absolutely agree. It's like this. So, any tablet, and quite frankly, whenever a patient comes to me and if I am to prescribe any medication, I'm honest with them. I'm going to tell them, look, any medication that we prescribe potentially can have side effects. These are chemicals. Yeah, potentially, yes. However, firstly, whenever we prescribe medications, we always, from our medical oath, we always will prescribe medications which we feel will benefit you rather than harm you, number one. Correct. If we feel the harm is going to be more than the benefit, we'll never give you any tablet. We are not going to prescribe. That's part of our oath, isn't it? First, do no harm, isn't it? So whenever we are going to give you a tablet, we don't give it with the intention of causing harm. That's number one. Number two, when we start medications, we'll always keep monitoring certain things which we know scientifically that could potentially can cause problems. And, if there is some, abnormality in the blood works or anything like that, we'll tell, look, your tablet is causing this problem. I'm going to stop it, or I'm going to reduce the dose, etc. So that's what we are. That's the first thing that we should understand. So to go back to this dementia issue, so that's again, so statins, which are commonly prescribed for medications, can have some certain side effects. The commonest ones are, muscle aches and pains. Potentially, that happens in about 1 in 1,000 people. The other issue is liver problems. That happens in about 1 in 10,000. again, the benefit will outweigh those risks. Dementia is one of those, real remote findings that has been, again, certain people who are anti-pharma, let's say, have described. But again, the answer that I give is pretty much the same answer that you told, isn't it? So whenever we prescribe a medication, we give it for cholesterol, we give it the intention of stopping a heart attack. So to get dementia, you need to live long enough to develop dementia. You will die of a heart attack much before if you don't take your statin. So that's the answer that I give.
Absolutely. The same thing I told her as well.
Yeah.
So, and speaking of heart attacks, Chamara, so I've noticed this trend now where a lot of young people end up dying from heart attacks. Even I lost a friend. I lost a classmate of mine last year for a heart attack. And there was another chap that was also, last year was just after the big match. Again, this year was also just, I think, a day or two after the big match, one of the junior batches lost one of their friends. What's going on? Why?
Yeah. It's an interesting question. It's, to quite honest, it's hard to put a finger and say why this is happening so commonly. Nowadays, I suppose young guys in their 30s and 40s. Recently, I had a couple of days ago, actually, a 35-year-old chap who came with a heart attack again. He came walking into my consultation chambers, actually, with chest pain, took an ECG. It's a hard, I had to give him the bad news. Look, I'm sorry, you're having a heart attack. We'll have to admit you immediately and treat you. So, yeah, it's very strange. It's hard to, again, say why exactly it's happening at young ages. I think it's multifactorial. I think a lot of things are happening in the world that potentially is causing these. Again, I think we are getting, so if you go by science, which I am a firm believer of, heart attacks, as I mentioned, happen because of certain risk factors that we have. So again, as I mentioned, just to recap what we just said before, high blood pressure, diabetes, cholesterol, smoking. Apart from that, those are the so-called traditional risk factors. There are some newer risk factors that we have found as well. So for example, psychological stress.
Correct.
Sedentary lifestyle, etc. So those kind of things also matter. And so of those, I think stress probably is one of those demons that we don't talk about, elephant in the room, if you know what I mean. With patients, sometimes we don't address it. And what I'm talking about is chronic stress as well, Sunit. It's not necessarily just, your cricket team lost a match yesterday and you're stressed out about it or anything like that. But it's just about chronic stress that sometimes we live with, which we sometimes are in denial about as well. And I feel that this stress factor triggers certain chemical imbalances in you. And that leads to these risk factors that you just mentioned, pressure, cholesterol.
Correct.
They manifest a bit earlier than maybe our parents or our grandparents.
That generation. If you analyze the two generations, Chamara, the stressors that they lived under, the stressors that we live under have changed.
Changed a lot, exactly.
So
I believe so. I think, in this country with all that happened with the economic crisis and, with COVID prior to that, lots of people had to lose their jobs, change their jobs, all of that plays a part, I feel. And, economic crisis, people had to, change jobs again, sometimes think about going overseas,
Correct.
All those
Correct.
things.
Yeah.
So all of that, runs in your mind. You may be, looking perfectly fine, but internally you're kind of churning there, isn't it?
Correct. Absolutely.
And all of that stress factor, I feel, is probably one of the major, I'm not saying it's the only factor, of course, but
Correct.
it's probably one of the major factors that is making these other risk factors manifest a bit earlier than before. And that's probably why we are getting people with heart attacks at a younger age compared to previous generations.
That's an interesting point you made, the stress. Like you said, although it's not the only factor, if you look at it, it's the factor that has exponentially increased over time.
Correct.
Because I don't see people smoking more than they used to in the 60s and when smoking was cool back in the day. Because they used to smoke way more back in the day. But although life expectancy has gone up, so has divorce rates, so has unemployment and things like that. So the subconscious stressors that add up have exponentially
and as I said,
increased.
it's chronic stress. It's something that just keeps accumulating. So I think I think the younger generation are under tremendous stress, isn't it? I think that's why they are unfortunately turning turning towards other, narcotics, etc. Those things.
Outlets for their stress.
Outlets for the stress potentially.
Outlets,
yeah, exactly. And that potentially could cause other issues, including heart trouble, etc. So I feel these are, unfortunately, manifestations of chronic stress. Is probably, to answer the question, I think it's not, still, let's say, scientifically proven, let's say. But if I were to, give a guess as to why younger people are getting heart attacks these days, I think it's probably that.
Good point. Very good point. So we mentioned smoking a number of times, and this is another elephant that I would love to address in the room, because so many of us smoke, men, women. I've seen it. I mean, I see this. It's like I said, it's something that hasn't reduced over time. It's been constant. So I would like to hear it from you about the role that cigarettes play on the health of the heart.
Fair enough. It's a good question, and I think just to add to that, smoking cigarettes, and the latest trend is vapes.
Yes, vapes. My goodness,
that's the question that I get asked a lot by young guys, because vapes. I went to for a meeting. Let's say it was again a educational meeting to a company recently. I'm just telling you this is and it was a very well established, well known company in Colombo, and I was asked to talk about heart health, etc. to corporate sector. I went, and then there was a glass room, and I said, what's going on there? They said, that's a smoking room.
Oh, smoking room.
And I was like, okay. And then I can see there are these multicolored, fascinating, like colored little gadgets all lined up. And I was, what on earth are those? Those are vapes. So like it's like in fantastic, lovely colors, and they're all the vapes of the employees who just go in and have a vape and come out. And I was like, what on earth is happening here, guys? Because there is this whole trend of vapes are safe, etc., isn't it? But unfortunately, again, so to come to the question, where cigarettes so unfortunately, as a cardiologist, I have to admit to the fact that cigarettes in whatever form, smoking cigarettes, vapes, etc., have absolutely no benefit as far as heart health is concerned. If anything, of course, it's going to be bad for you. It's going to lead to heart attacks. One of the leading risk factors that can lead to a heart attack at any age will be cigarette smoking. But the reason is that all what you smoke, it's not the smoke itself, of course. It's the chemicals in it. It causes. So your heart has blood vessels called coronary arteries, and we have this buildup of plaque, which can be minute, it can be significant, it can be minor even. However, when you smoke, and those chemicals can cause that plaque to rupture, it can break off. And if it breaks off, it forms a blood clot, and it can block that artery completely. So even a minor plaque can get ruptured and lead to a heart attack if you smoke. So that's the worry. That's why even smoking a single cigarette, unfortunately, can rather end up in you having a heart attack. So some people come and tell me, Doc, it's okay, isn't it? I just smoke a cigarette. Sometimes I have a drink. When I have a drink, I smoke. That's okay, right? I say, unfortunately, mate, it's not all right. Unfortunately, all right. I can't say it's okay. Even a single cigarette can potentially lead to a heart attack in the future. So as a cardiologist, I have to always advise whoever comes and asks me whether cigarette smoking is okay or vapes are okay. Again, vapes, similarly, recently have been found to be as bad or even worse as far as heart health is concerned.
Absolutely. That's a good point you brought up. I was about to mention that myself. When I'm asked this, I read up on this extensively because I'm constantly asked this question. Yeah. See, vapes have been around for like 10, 15 years, right? But we've been smoking for centuries. So we have long-term data on smoking that says it's bad. It causes cancers and all these things. We don't have long-term data on vapes. So whenever people ask me this question, I reply, do you want to be a statistic?
Yeah, exactly.
Because the short-term data shows it's worse than the short-term data of smoking. You compare the two, vaping is worse, like you said. So you can, if you're intelligent enough to extrapolate that, it's not going to be any better on the long term.
I think, right? Yeah, exactly. And unfortunately, I think we have to blame I suppose the culture of it as well. People thought that vaping was cool.
Yes, correct.
And the companies, they came up with novel ideas how to kind of propagate it. They came up with different flavors, etc., isn't it? So it becomes an addiction, and it's a new, it's a cool thing, as the kids call it these days. So yeah, unfortunately, and I think as it was introduced, certain countries, the governments, they kind of wanted to shift cigarette smoking to vapes, and they were kind of encouraging it. Exactly. So unfortunately, that was also a bad, I suppose, move from those countries as well to kind of encourage vapes over cigarettes, but because they thought that it may be safer. But unfortunately, the data, and we have to believe science again, isn't it?
Yes,
the short-term data, as you mentioned, shows that vapes are as bad or sometimes even worse. As far as heart health is concerned, it's worse than cigarettes, is what they found.
True.
Yeah.
There you go. So another thing that I want to talk to you about, taking a bit away from smoking and all of that. I'm sure you have the same problem. I have the same problem as well. There are a lot of patients who come in, with maybe a non-specific chest pain. And the first question is, doctor, I want to do an angiogram. Why do you want the angiogram? Because I've read somebody had an angiogram. They found so many blocks. I'm sure this is also the same problem, and they demand an angiogram. So what I want to ask from you is, first of all, let's tell our viewers what exactly is an angiogram and why you as a cardiologist wouldn't jump and do it for everyone and their mother.
Yeah, it's a good question. There are so many, people who come with various things. There are people who are dead scared of an angiogram. Even those who need an angiogram are dead scared of getting one. And then there's a certain amount of the population who actually don't need an angiogram, who come and ask us, can we get one done? So it's very strange. It's one of those enigmas, I suppose. But just to simply say what an angiogram is. So an angiogram is a invasive investigation. We have to call it invasive because we go into the heart. So we do it under certain preparation. Patients are fasting for about 4-6 hours. There are two accesses where we enter the heart. The commonest one is through the wrist here. It's called the radial artery. There's an artery in the wrist. And in certain people, they go through the groin. But commonly, we go through the arm and the wrist because it's simpler, and it's better for the patients where they can mobilize rather than going from the groin. It's done under local anesthesia, so the patients are awake during the procedure. Where we insert a tube which goes up the arm or the groin, and we enter into the heart, and with that tube, and we look at it from a camera, which is a X-ray tube, and we can then inject this contrast or the dye into the coronary arteries themselves. And when we inject it and when we X-ray it from the tube, we can see the exact blood flow in those coronary arteries and whether there are any narrowings or blocks in those coronary arteries. So that's what an angiogram is. So to answer that question, whether, who needs it and, who doesn't need it. So people who have a heart attack, wherever in the world you may be, if you have a heart attack and it's confirmed that it's a heart attack, an angiogram is the way to go, because the specific treatment that we prescribe for a heart attack, for example, what we call angioplasty, where we insert stents, or if the patients require bypass surgery, etc., we determine whether they need that specific treatment by performing an angiogram. So if you have had a heart attack or having a heart attack, an angiogram definitely will be warranted, and it's the best way to know and to treat that specific condition. There are certain people who have, say, a condition called angina, where it's not a heart attack, but it's kind of a heart attack waiting to happen, let's say, and we determine it by for certain tests. For example, an exercise ECG, where we do an exercise ECG and it's positive, where we have some clue that you may be having blocks in the arteries of the heart, then an angiogram may be warranted. But those who come with specific, non-specific rather, chest pains where we are not sure whether it's a heart attack or not, or angina or not, then of course an angiogram is not necessarily warranted. We need to, I believe that we need to always go stepwise. An angiogram is probably the last step of a whole process of investigations that we will recommend to any patient who comes to us with chest pains. So the angiogram is kind of a last resort, if I were to say so. But there are so as I mentioned, an angiogram is an invasive procedure. So an invasive procedure invariably would lead to a certain amount of risk involved as well. So if I talk about risk, the risk of you getting a heart attack during an angiogram is about 1 in 5,000 people. It's not a massive risk, but a risk nevertheless.
Still, yes.
Yeah. And potentially, life-threatening problems as well. So again, the reason we will do it is if we feel that benefit will outweigh that risk.
Absolutely.
So we'll always recommend it to somebody who will definitely need it. But if you don't need it, we'll never say, look, you need an angiogram, because whatever said and done, 1 in 5,000, you may be my 5,000 patient who might end up with a complication. So
Correct.
I will never ask anybody who doesn't need one angiogram to get one done. But there are non-invasive investigations as well, Sunat, so that we can determine whether you are at risk of having heart blocks or not. So a simple one is, as I said, this exercise ECG. There's a novel scan called a CT angiogram, which is a non-invasive CT scan of the heart, which is available, and that is a good way to know, and quite a specific way of finding out whether you have blocks in the coronary arteries or not. So that's a recommendation that I usually give my patients as well, a CT scan of the heart rather than going with an invasive angiogram, just for diagnostic purpose. But an angiogram I won't recommend for everybody, but if you need one, you need one, but not everybody will need it.
Understood. So just to clarify, a CT angiogram still needs the contrast dye, isn't it?
Correct. CT angiograms will need the contrast dye, but it's given to the vein in the arms generally. So the risk of complications is, almost zero.
Much less than an angiogram.
Since it's not invasive.
Right. So the other reason I brought this up is I had a patient, the chap said something very interesting. So he came with, again, very non-specific symptoms, and I recommended that we do a cardiac assessment, and maybe, actually, I wanted him to come to you and get an echo done. And I said, at the worst, Chamara may do exercise ECG. So this guy, of course, again, well-read, well-Googled, is like, but doctor, aren't 50% of exercise ECGs negative? Yep. So therefore, don't you think we should do an angiogram?
It's exactly. We deal with these kind of patients. I suppose intelligent question from him as well. Which again, so the exercise ECG, as I mentioned earlier, is a very basic investigation. So the accuracy is about 50-60% only. There are plenty of guys who have come to me with heart attacks, who have told me, Doc, 3 months ago, I had an exercise ECG which was completely normal, and now you're telling me I have a heart attack. How is this possible? So that's the issue with exercise ECG. It's a basic, simple, inexpensive investigation. So we do it as a screening. We do it as a very basic investigation. But when anybody comes to me with a exercise ECG which is normal, the disclaimer I always tell the patient, the disclaimer here is that although you have a normal exercise ECG, I can't still guarantee. Some people have that false reassurance. Oh, doc, exercise is normal,
all good.
I'm fine. Nothing to worry about. I'm going to live till 100. I was like, look, that I can't say. You might get hit by a bus even.
Tomorrow, exactly. Yeah.
But the exercise ECG's accuracy is only about 50-60%. I can't guarantee that it's normal, but reasonable accuracy is there. If you want 100% accuracy, get a CT done. But I know. I'm not going to force it on you unless it's absolutely necessary. But the exercise, that's the thing. So unfortunately, the CT angio, which I mentioned, non-invasive, good accuracy, very specific. But as you go down, go up the ladder rather of investigations, the cost factor comes in as well, isn't it? So we need to be practical about what we do and who we recommend it to also. So we have options. We just about trying to figure out what is best for each patient. So that's why you would have heard in recent medical talks and all, we talk about a so-called individualized approach, isn't it? So we can't just take people at face value. We need to figure out what their situation is, from symptoms to, economic situation, etc. And then we figure out what is best for them and deal with it at the time.
So each individual has to be dealt on their own merits.
Correct. Exactly. I think that's the best way to go about it.
Right. Right, Chamara, thank you so much for your time. It has been an enlightening conversation.
My pleasure.
I do want to make one point though. I mean, yes, cardiology doesn't just mean heart attacks. There's so much more beyond that to discuss in cardiology. But I took up the commonest questions that you and I have faced over time. There's so much more to talk about rhythm, about pressure, about heart enlargement, and so many other things. So if you have questions for Chamara, please comment below. I'll answer the first one. Yes, he's married. Back off, ladies. The man's taken. But beyond that, if you have any other questions, please do comment, and we'll get Chamara back when he's free. He's a busy man, but I'm sure he can make some time, and we will answer some more of your questions. In the meantime, Chamara, thank you so much for being on the show.
Thank you very much for having me, Sunit. Thank you.